Hi, welcome to the More Than Tested Empowered Breaking Barriers to Care webinar. My name is Lisa Al-Hakim, and I am the Director of Operations for People's Harm Reduction Alliance. Next slide. Thank you. There we all are. Look at that. So meet your panelists. We have Luis Vincent, which is the Executive Director of North Carolina Urban Survivors Union. Dr. Moran Zar, did I say your name right? Or John Zar? I'm terrible. Okay, Executive Director, Atlanta Harm Reduction Coalition. Me, who I've already introduced, and Shiloh Jama, who's the Executive Director of the People's Harm Reduction Alliance, who is not on this video call, but did contribute to the webinar. Next slide. Breaking those barriers down, look at that. So we have been doing this project for, I guess this would be our 4th year coming up, the last several years. So we've been working with Atlanta Harm Reduction Coalition and North Carolina Urban Survivors Union. And we started this to identify the barriers to hepatitis C testing and also treatment within our programs, which are primarily needle exchange programs that have kind of morphed into drug user health, I guess, hubs. So we just wanted to see how we could make it easier for folks to get tested for Hep C and treated for Hep C as well, because as we all know, Hep C affects drug users more than it does other populations. So we're all in some pretty different areas. Obviously, we're in Seattle, Washington, which is a pretty liberal area with a lot of drug policies that are pretty forward-thinking, and you know, I sometimes forget until I come and work on projects with other folks that it can be really a lot different in other places in our country. And so the biggest barrier to Hep C treatment that I think we all identified across the board, no matter where we were, with stigma, you know, having issues with the medical industrial complex, being treated poorly because you're a drug user, people not wanting to go to the doctor because, you know, they're scared, and that sort of thing. So just that sort of separation of, yes, I want to get tested, yes, I want to be treated, but then the minute you have to go to the hospital, it's like, no, I've changed my mind, I don't want to do this anymore. So throughout the years, we've made some pretty big strides with our Hep C testing program at PRA. We've made testing available at our fixed sites and our mobile sites. So I think almost every site that we have, except for our Everett site, and we have 5 sites total, has hepatitis C testing. And then a lot of those have linkage to care and also case management. So next slide, please. Okay, so again, with the success of our hepatitis C testing at PRA, we made it available at all our sites. And we also partnered with some other programs. We had been testing for hepatitis C at our University District location before we started the More Than Tested project. So we kind of had a jump on that. We weren't testing as PRA, but the Hepatitis Education Project was testing for us every Friday. So it was once a week at one of our locations. And over, you know, these 3 years, we've ramped it up to every location. And Hepatitis Education Project is still helping us out with doing testing, and they've been great. And we wouldn't be able to do any of this without them. But we've been able to get testing, you know, in-house, and then our folks trained up to do the testing. So we do have rapid testing at all our mobile sites, all our rural sites, and all of our and our one brick and mortar site. We have confirmatory testing at our brick and mortar site as well. And we are working on getting that on our mobile sites. It is on one mobile site right now. But because of COVID, we aren't doing confirmatory testing on the mobile site at the moment because there's just nowhere safe to do that, although we think we will probably ramp up again pretty soon once we can kind of suss out a way to do that safely. So folks receive incentives when they get tested with us. So it is $5 cash to get a rapid test, and then they get a little bit more money when they get the confirmatory test when they come back and get their results. And so that, you know, helps with people wanting to get tested and helps. And it's great for us because then we can give our folks money, which we love doing. So we have also added telemedicine for our rural counties for the actual treatment in King County, which is the county Seattle's in, and our physical side is that we actually have case management, like physical case management will go to the doctor with you because the doctor who treats all of our folks and we feel comfortable with is located in Seattle. So for our rural places, we just do telemedicine with that doctor because there's still a lot of stigma in the rural places where they won't treat people who are actively using drugs for hepatitis C. So we've had to kind of work around that, although we have identified some folks in rural counties who are interested, and we have some programs here where people who aren't specialists can treat as long as they join this program called the ECHO program through University of Washington to kind of be overseen with testing hepatitis C. So the barriers are getting a lot lower going forward here, you know, with our state as we go along, which is helpful for us. So next slide. So again, throughout our years of working with trying to tear down the barriers to curing hep C, we've made a lot of strides, but most of the stuff that, most of the barriers that existed in the beginning are kind of the same barriers that exist now. As I said before, people being treated terribly when they're within the medical system by doctors and nurses and hospitals. And, you know, I want to say that doesn't mean all, you know, doctors and nurses, but, you know, I think we all know, as far as the medical system goes, people have been treated pretty badly who use drugs. So people have been made to feel shameful about their drug use, you know, and the medical system has failed drug users. I think can ask anybody who uses drugs if they've been honest about their use to their doctor, or even if they have a doctor, and, you know, it's always going to be a no, because why would you? So as a result of that, many of the syringe exchange programs, we've expanded our health services, most of us without additional funding, to serve the needs of our folks because they're not going to go seek medical care. So we've been trying to expand our services so we can kind of, you know, be that primary care for them because in the, you know, that's harm reduction. We're not doctors, but we definitely know what we're doing, and a lot of us have lived experience, so we've been taking care of ourselves and each other for a long time. So I think that we're pretty equipped to take care of our folks, and we know what their issues are. So next slide. There it goes. So our previous webinar, if you were on it, focused on COVID-19 and the impact it had on drug users, and people obviously had hep C and people who live outside as well. That created a whole new set of barriers that we weren't banking on. So as per usual, we have to shoot from the hip and try to figure out how are we going to navigate this on top of the barriers that already exist. So what happened here was there was a pause put on our hepatitis C testing until we could come up with protocol for our rapid testing and our confirmatory testing that would protect our participants as well as the volunteers and the people who work for PRA. The other thing that happened is doctors in Seattle stopped taking new hep C participants for treatment. So I had somebody lined up to go in, I think it was a week away, and then the doctors just stopped taking anybody. So I had to go back and tell him, you know, we're gonna have to wait. And he was pretty upset because I think he was really ready to go in. And so, yeah, that was really hard. And I think those are some of the things that I didn't see coming, and just had to work through and make sure to stay in contact and ask how somebody's doing, and just keep in contact with the doctor and see when they're going to take new people. And but again, that was that was really hard for him, and he was ready. And now he's just, he's got a really bad skin infection now and these sorts of things. So I think when people want to be treated for something, they should be able to get that treatment right then. And even though there's an epidemic, our pandemic, I should say, because we're already in an epidemic of sorts. It doesn't mean that we stop treating, everybody else's ailments, and also folks who live outside. I mean, the pandemic is awful for them, and not so much because of the actual pandemic, but just all the things that have been surrounding that, and what's been happening with the loss of services and that sorts of things. So they can't go to the doctor, which it's loosening up a bit now, but that was definitely something we experienced for months. So the next slide. So yeah, the domino effect. So throughout our project, one thing was pretty constant or consistent. It's that people, would get tested with us, and then they would get confirmatory testing, and then we'd be like, okay, you're positive for Hep C, like, let's get you set up with an appointment. And they'd be like, wait, what? I have to go somewhere else? Like, I have to go to Harborview? Like, I'm not going to go to the hospital. No, I thought this was happening here. So we had people just not interested anymore because, they don't want to go to the doctor. And I think, it's like pretty clear in the beginning about, if you test positive, this is where we're going. But I think people think sometimes that we're magic and we can just like make it happen in-house, because we do that so much with things. But, in this instance, it's pretty unobtainable at this point. But definitely it kind of put a magnifying glass, I think, on a lot of things for all of us, but especially in this project of, if we had the ability to treat folks for hepatitis C in-house, we didn't shut down during COVID. We didn't even change our hours. In fact, we expanded. And so we would have been able to manage people's Hep C treatment if we would have had an in-house provider, or even, telemedicine, something like that. We could have put a whole lot of people through, Hep C treatment and cured some folks. And, that's our Washington State's goal, to have hepatitis C eradicated, per our governor. So, we think it would be pretty useful to allow us to have in-house treatment for our folks. We think that we would have a lot of folks interested at that point if we were able to offer that. So next slide. So like I was saying, implementing treatment and syringe exchanges and trusted community programs, is really going to be the only way we can eradicate hepatitis C. Like I said, we've seen people drop off the continuum of care time and time again because they have to go to the hospital. People are just not interested in that. And I personally understand why. I think all of us do. Until something changes, which is going to have to be a pretty drastic change, because the damage has already been done and that relationship is broken. So, that's another conversation. But right now, I mean, maybe this means, we just need to go and, serve our folks the best way we know how. And that means offering all of these sort of basic healthcare things in-house. And so, again, I think what we're trying to work towards is offering in-house care. And I think a way we can do that is through telemedicine. Something, like I said, we've already been using in our rural counties. It's been working for folks. So I think this is where we're headed this year going forward, is trying to actually bring hepatitis C treatment in-house. So next slide. We did want to do. So yeah, that's where we're going, headed forward. We're going to offer, you know, telemedicine. We also have doctors that work within our program, that we're looking at different things where, you know, maybe we can have the medications on site and this sort of thing. So I think we can get really creative with it, but telemedicine is definitely something that we 100% can do right now, and that's where we're headed with that. And we did want to acknowledge our longtime collaborators and friends of the Hepatitis Education Project, for all their support on this project and throughout the years. So we couldn't have tested, expanded our Hep C services at Pro without their guidance, really, and then all the help they've given us along the way for free. So we just wanted to give an extra shout out, and just, you know, having community partners is something that's necessary, you know, I think, to the success of serving folks, because you might think you have all the answers, but you don't always. So these things are really important. Yeah, and that's I think that's the end of my. So next slide, I guess.
Thank you, Lisa.
You're welcome.
Hi, my name is Moj Ganzare, and I'm the Executive Director at Atlanta Harm Reduction Coalition. I am also the PI for this project that Lisa did a wonderful job explaining, the connection between all the organizations and kind of like what our vision was when we started this project about maybe 3 years ago now. So I would like to start by kind of giving a little bit background of who we are. So Atlanta Harm Reduction, we're a community-based wellness organization, and we're committed to promoting health and dignity by reducing the impact of HIV/AIDS, hepatitis C, STI, and substance use within vulnerable communities. We envision a world where all people are accepted, valued, and share access to healthcare and support that leads to a fulfilling life. And with that, it takes us to our Connect to Care clinic. So just to give a little bit of background about how the clinic came to being, so similar to what Lisa was explaining, you know, we were also seeing all the barriers that were existing when it came to our patients who were living with hepatitis C and who were actively injecting drug users or actively using substances and having a tough time getting into medical care solely due to their social habit and the hurdles that they had to go through in order to actually receive care, which was much more than a person if it was another person who wasn't actually using. So we had a hepatitis C program. The hepatitis C program was developed and implemented at AHARC about 6 years ago now. And so what we have been offering throughout the past few years is that we do the preliminary testing, which is the finger prick. We were doing it within our center. We were also doing it through our mobile health unit. We then started providing confirmatory testing through a collaboration with our state health department. And then through our linkage to care department at our organization at AHARC, we were also linking patients to care. Again, going back to the stigma, we were having a really tough time with that. And so what we identified, again, similar to what Lisa was explaining, was the stigma was one of the big factors around it. Again, because of injection drug use and substance use. But we were also seeing rejection from the healthcare providers for our patients who were actively using and who were living with hepatitis C because of the fear of reinfection or not being adherent to medication. Cultural competency was a huge factor when it came to the healthcare providers that we were sending our patients to. Now again, Lisa mentioned it, and I'm so grateful to her that she mentioned it, that this is definitely not targeted to every single healthcare provider and to every single, and when we say healthcare provider, it could be from front desk to a medical assistant to the actual physician or a mid-level provider. But we definitely do see a fair share of medical providers who just, their office and their team do not have the culture of competency to work with our clients. And then, of course, finances. Again, like Lisa explained, we are located in 3 different territories or 3 different locations. So Louise, who is in North Carolina, as well as myself and Louise, I'm sure we'll go into detail with that as well. But with definitely with Georgia, we are in a non-Medicaid expanded state. So that means no insurance. And people who are living in the level of poverty, or they do not have any income, they fall through the crack. They are not, it's again, non-Medicaid expanded. So they're not eligible for Medicaid. They can't afford commercial insurance. And so basically they can't afford to pay for the cost of the services to the actual healthcare provider either. So that just puts them at, unfortunately, a difficult position of not being able to receive services. And then, of course, there are always other barriers such as transportations and, things of that nature that that prevents them from being able to get to appointment on constant basis. So even though there's there are these wonderful drugs out there now that can cure patients who are living with hepatitis C, we were seeing that our patients were not able to do that. So that led to then in the development and implementation of a new program at AHARC, which is the Connect to Care Clinic. And so in 2000, just to give a little bit history of the clinic now, the center of why we decided to create the clinic itself was to provide treatment for hepatitis C to our patients who we were identifying as living with hepatitis C. We knew we have obviously a team that are culturally competent when it comes to people who inject drug and people who use drugs. And we have a certain services program right within us. We are harm reduction, and Lisa kind of mentioned that, we have people with living experiences. We've been taking care of each other for a long time. And, so all of that led to, kind of wanting to develop the program. So although Connect to Care Clinic started with hepatitis C treatment, later on, we added all these other services to make it more comprehensive infectious disease. So now within the clinic, we do provide HIV rapid entry to care as well as follow-up. We do provide PrEP treatment. We do provide hepatitis C treatment. We do STI screening and treatment. We also do limited women's health. We do preventative care, such as vaccinations and glucose check and things like that. We do telehealth services as well, understanding that not everybody is able to come to us to receive services, and they have other responsibilities that they need to take care of, especially now, with the emergence of pandemic COVID-19 transportation and coming to our clinic. For so many of our clients who were using transportation may be very difficult. Of course, we link, we understand that our services, is not, we do not provide all the services an individual will need, but we do provide, so we provide linkage to care, of course, to other facilities as well. We do provide education and evidence-based interventions. And finally, in the fall of 2020, we will be starting a medication-assisted treatment, Suboxone, within our clinic. So the goal of the clinic then became to bring a voice and access to medical care for people who use drugs, as well as any other community or population where they were stigmatized. And so because of that, we just, of course, just like any of our other programs, the Connect to Care Clinic, again, it is a program within us, and it is an actual clinic as well. So it is centered, or it's just the strategy of it is centered around harm reduction. So it is a clinical intervention, and it focuses on providing confidential and culturally appropriate treatment options to our patients and clients. We do have an experienced medical team, which I will introduce you guys in a few minutes. And we work with every single patient in identifying the best medical treatment that fits them. We do not, and one of the interesting things about the Connect to Care program is it's not a generalized treatment. Every single individual comes with a background that is completely different, and a lifestyle that's completely different from other people. And we want to make sure that we honor that. We do indulge we do make sure our patients actually, we have conversations with them to make sure that the treatment option is also acceptable to them as well. This is something they can do. This is something they can follow up. And as far as the insurance and the finances, that was the issue. Of course, this is a no fee clinic, so we do not charge our patients. If they do have insurance, we'll utilize their insurance. We also understand there are not that many of our, unfortunately, patients who do access insurance. If they are, approved to receive government benefits such as Ryan White, then we do utilize that. But otherwise, if they cannot utilize any of these stuff, and we do not charge any fee from our patient, and this is how it becomes accessible for them. And of course, again, with the cultural competency, all of our medical team as well as our agency staff members and volunteers are all culturally competent. They continue to receiving cultural competency courses to make sure that they, we can provide services to our clients in the way that they should be receiving them. Next slide, please. Okay, so when it comes to stigma, which is, again, like Lisa was indicating, and I'm sure Louise probably will indicate within her presentation as well, stigma was identified, of course, as one of the biggest barriers, when it comes to hepatitis C treatment among the population that we serve. And so in order to break stigma, in order to address all of these issues, we had to identify what are the root cause of the problems for stigma and how can we go ahead and address them. So we have come with some different ideas, and we've been incorporating them into our clinic, into our program. So of course, this is something we've been doing for the past 25 years that AHARC has been in existence and in operations, is subject matter expertise and voice. So in every time, we do our strategic plans, which are multi-year long, every time we do some sort of feedback, every time we do a program, things like that, we always get voices of people who use drugs and people who inject drugs within our community members, and we receive feedback from them. At the end of the day, if you create any program for any specific person, the program needs to fit them, and who better to explain if this program actually works well for them or not. Unfortunately, I have seen so many programs where there are people around the table who make these decisions who have no idea, they don't have any understanding of this specific culture or this specific use or whatever the case may be, but they make the decision, and the person whose the subject matters are completely excluded from these decision making. So that is something that AHARC has definitely been doing. I think a lot of harm reduction, just about any probably harm reduction organization has been doing. We also implemented first person language. So we do not, indicate injection drug users. We do not indicate substance users. It's always people who inject drugs, a person who inject drugs, a person who's living with HIV, a person who is disabled. And so that is done to give power and to show respect and to, work with the individual. Again, we already talked about engagement in treatment as a collaboration. And then we also kind of, help all our patients when it comes to any of their other barriers, such as this could be transportation issues, this could be insurance issues, even down to filling out paperwork. So many times you see people walking into a place, they hand them a bunch of paperwork. It's very difficult to fill out for many different reasons. It could be physical disability. It could be very difficult medical words or whatever. And here at our clinic, we make sure that we treat it just like a spa, and we fill out paperwork for all our patients. And last but not least, this stigma again around, or this kind of expectation of every patient has to show up for an appointment. There's so many reasons why our patients are not able to make it to an appointment, especially now during the pandemic of city shutdowns and transportation issues and things like that. So we, of course, we provide, we allow for walk-ins, and we accept every single walk-in who comes to our clinic. Next slide, please. So this is our medical team. I serve as the medical director. Dr. Ailey Kalapila is one of our infectious diseases specialists who works with Grady Hospital, a nearby hospital, and she comes to us as well. She sees patients at our clinic. We have a full-time mid-level provider, Miss Walker, who is a nurse practitioner. We also have a part-time mid-level provider, Miss Newman, who is a physician assistant. We have 2 medical assistants, Nikia and Eternity, and we also have a registered nurse, Sarah, who does a lot of our work in outreach. And one of the services that I forgot to mention is wound care. Wound care is extremely important and needed when it comes to people who inject drugs and at certain services program. And Sarah has been wonderful in attending certain services program and helping with tending to wound cares. Next slide, please. Okay, so let's talk a little bit about connection of our syringe services program, which is our oldest program, as well as Connect to Care Clinic, which is one of our newest program. So we are literally, so our syringe services program, let me say this, our syringe services program is conducted via mobile health unit. So it's an outreach site, and it is done 3 times a week. But 2 times a week on Mondays and Wednesdays, it is literally a mile away from where our agency and our clinic is located. However, even though, patients would essentially come to the clinic to receive treatment and services, even then we realize that 1 mile, even though it's for many, it may be nothing. If you drive it, it's going to be a 5-minute drive, right? Or less. But even that 1 mile could become a barrier. Plus, what we identified is when we talk about syringe services program, there are many ways that you can implement it. There are fixed sites and there are mobile sites. And then we can talk about what are advantages and disadvantages of each. But the advantage of a mobile site is that everybody who goes to that specific location for the mobile health unit, they know that everybody else who also comes to the mobile health unit are people who are going to exchange needles or receive other services specific to people who inject drugs and people who use drugs. And therefore, they feel much more comfortable. The stigma is not there. They don't feel like they'll be going to a center who some other person may come and see them, and they may not want other people to know. So there are many reasons behind this. And so that's why we also identify that this is important that we provide treatment within our SSP. And so this connection made us unique in that, there have been other programs in the United States, but they've collaborated with other medical providers in providing treatment within SSPs. But then we became kind of the first in becoming a model for other harm reduction organization is providing care and treatment within the SSP with our very own clinic. So what we do is we go to the SSP site, the medical team goes there, they connect with the patient, they do get tested through our prevention team for hepatitis C, then they do the confirmatory, the medical team start with the confirmatory, the connection, the education, and start with the initiation of the treatment plan. If the patient still needs to go to the clinic for whatever reason, the medical team makes it happen and they help with the transportation. So this way, all the other stuff like transportation issues, getting lost, feeling overwhelmed, feeling like, oh my God, I don't know what this clinic people are like. I know these syringe exchange people who these guys are. All of that stuff then are removed. And our hope is that we use this model to kind of provide it to other harm reduction organizations, as well as other service organizations, CBOs across the United States, so that they can implement it and start providing care for people who use drugs and who inject drugs. Next slide, please. Okay, so let's just do a quick review. So this is what our process looks like. So somebody comes to our syringe services program, to our clinic, to our testing center, or to one of our venues, and get tested for a preliminary, which is a finger prick testing. And if that test is reactive, then they will get, through phlebotomy, blood draw, they will get a reflex test, which shows both the antibody as well as the antigen. And then also we make sure that we test then the individual for hepatitis B as well, because, we want to make sure that if they're identified with Hep B also, that they receive care and treatment that they need. And so that goes to the lab. And once the result of those come back, if they are identified with living with hepatitis B, we connect them to care. We do not provide that treatment, unfortunately, with our Connect to Care clinic at the time. So we connect them to care. But if they are identified with hepatitis C, then we can start initiating treatment. So they are seen by a provider. A physical is done on them. We do a CBC, I'm sorry, it's misspelled over there, CBP, but it's a CBC, which is complete blood count cell. We also do a comprehensive metabolic panel on them to check their kidney functions and things like that. And we send them to the lab. And, you know, of course, we still offer them HIV tests and STI tests and all of that stuff to make it comprehensive. And depending on where they are, if they're insured, we use their insurance. If they're eligible for insurance, we help them with that. If they're not a problem. Again, this is a no fee. And then we help them as far as medication. You know, right now, the 2 different companies who provide hepatitis C medication, we connect them with those to receive their medication, through medication assistant program to receive their medication. And then as far as their medication goes, so we use a pharmacy, a special pharmacy called Boca Specialty Pharmacy, and they are amazing is that they send the medication literally in 2 days. I'm sorry, within 24 to 48 hours. And then finally, we also, our medical teams help with medication adherence. And last but not least, they, you know, referral for other services as needed. Next slide, please. Okay, so then we have a linkage to care program, and this program is the center of all our programs. This is a program that have amazing cultural competency. They work with our clients and patients to ensure that all their needs are taken care of. So they provide education, they make sure their basic needs are met, they engage them in evidence-based intervention, they follow them up to 12 months, depending on the need of the patient, to make sure they can make it to their appointment. How are you feeling? Are you taking your medication? They link them to other programs at AHARC, and then once the hepatitis C antigen or, you know, is completely removed from their body, then they just follow them up to make sure that no reinfection takes place. Next slide, please. And thank you so much. And with that, I am going to turn it over to Miss Louise from North Carolina Urban Survivors Union.
Hello, my name is Louise Vincent, and I'm with North Carolina Survivors Union. And today we're going to talk about using story sharing to better understand women who use drugs and the structural obstacles that stand in the way of our health. So for the last 3 years now, we have been working with people who use drugs and looking at barriers to care around hepatitis C testing, treatment, and cure. We are using the narco-feminism model for story sharing, and I'm going to tell you a little bit more about that. Next slide. Okay, so we developed a 12-week course using all the materials from year 1 and 2. Basically, we developed this program with drug users at NCSU, all of which had lived experience. We implemented the program using program planning, and we are in the process of evaluating the program using focus groups and listening guides. This is part of a larger narco-feminism story sharing collaboration that we are working with reproductive justice, overdose, and other projects. So we bring the narco-feminism group into different projects that we're doing, but bringing it into our hepatitis C work has been really exciting, especially after we developed this 12-week course. Next slide. You can move it on to the next slide. So we're going to just run through these. We've gone through them, over the years as we've done this work. The barriers to care as identified through focus groups and interview data and personal experience around women who inject drugs and women who use drugs. Women are often blamed for bringing hepatitis C into a relationship. There's a lack of harm reduction resources for women who use drugs. Basically, providing services for women is not a specialized service. It's 50% of the population. And so these are services that we need to be providing. So providing services for non-men really needs to be commonplace. And we see syringe service programs as not doing a great job at making sure that there are services that are for women and non-men who use drugs. Of course, drug policy and laws prohibiting the sale of syringes, poor drug education throughout the entirety of our educational system. So people just don't have good understanding about disease risk, and the dangers of substance use and what the truth is about substance use. There's certainly confusion about HIV and hepatitis C risk factors. A lot of times we'll hear somebody say, well, I already slept with the person, so I might as well inject with the person. And that's someone that clearly doesn't understand the difference in risk factors, right? So we're not going to be put near as at risk by having sex for hepatitis C. And injection poses a much greater risk. So there is often confusion. And I think a lot of times because people teach HIV and hepatitis C many times at the same time. An inability to protect oneself related to power and division of drug supply. So a lot of times whoever has the power in the relationship is the person with the drugs, and they are in control of how the person is able to get the drugs into their body, who makes the injections, who makes the shots. So enforced requirement of sobriety within drug treatment. This is always problematic. Whenever we force sobriety, we end up pretty much ensuring that people that need help won't get it. Poor relationships or no ties with medical providers. We spent all last year looking at health relationships and health homes. And most of our participants did not have anything that they would call a health home. And stigma from drug using in larger communities, from family and internalized stigma. So for drug users, the stigma comes from everywhere. The stigma comes from our own community. The stigma comes from other drug users. The stigma comes from a larger community. The stigma comes from family. So lots of stigma that we're dealing with, lots of negative interactions, lots of people blaming themselves. Next slide. So here are some more lack of trust, skill, but here's some of the basic, some of the barriers that we see more often. Cost of treatment, lack of insurance. Dr. Zari was talking about being a non-Medicaid expansion state. That's certainly the case in North Carolina. Lack of knowledge around new treatment options. People just don't know that we're not talking about interferon. Lack of trust. There's just not enough information about how to properly inject drugs. It seems as though we're scared to teach people how to do that. It sure is better to teach them how to do that than let people try to figure it out on their own and cause themselves lots of harm. Lack of trust in institutions, fear of loss of bodily autonomy, abusive treatment and treatment trauma that people experience, and then complications with opioid dependency and sickness. So making it difficult to get to appointments on time or anywhere on time when you are dependent on a substance and must have it before you can go. And then underground employment, which is not based on a 9-to-5 schedule. This can often make it really difficult to be somewhere at 8 in the morning or 9 in the morning. People really struggle with keeping appointments. And a lot of times because of their underground employment. So we need to take that into consideration. Next slide.
My mom and my dad separated when I was like 5 years old, and he was in and out of prison and on drugs, and I really didn't have a relationship with him at all. But when I found out he was dying, I didn't want him to die alone. So I came from Texas to take care of him. And he had quit drinking, and we had a really good relationship. So I was really, really thankful for the time we did have. He started getting really sick and started swelling up and stuff. he went to the hospital and they admitted him, and they were like, well, he probably has about a month or two. And I signed some do not resuscitate papers. I was there visiting. My mom called, and she was like, well, let me talk to him. And they hadn't spoken in a long time. And she's like, I just wanted to let you know that, I've always been in love with you, and you were the love of my life. And you gave me 2 beautiful children, and I forgive you for everything that's happened. And you can see my dad tear up. And that night, they called at like 5 in the morning and said that his blood pressure was like 50 over something, and that he needed to come say goodbye. And I was able to talk to him for a couple of hours. The whole time I was there, he didn't blink, like forever. He didn't even blink. I know he heard what I said, because when the heart stopped, his eyes closed, and just all these tears came out. And it was just really hard to watch him die that way. And so when I found out that I had it, and I gave my daughter that too, my boyfriend, it made me feel really guilty about it, because I was the only one that had it, and they had used needles that I had used. I spent a year in prison, and they tested you here there.
Did your daughter and boyfriend use your needles? So that was before or after you were in prison?
It was before.
So you didn't know?
Yeah. I haven't ever felt bad from I haven't ever got sick or anything.
What has it been like to try to get treatment?
They said that I don't need it yet because I'm not sick enough, I guess. They said you had to be having symptoms, and or at least the doctor I talked to.
Have it enough to
Test positive for
spread
it.
it?
Right.
Yeah.
Yeah. I don't know how I got it. I guess I could have contracted it from taking care of my dad. Really know.
Thank you. I need to get back to the slide set, so I'm going to try to pull this back up. Okay, so some of that was hard to understand, but what's really important is when she's talking about hepatitis C, one of the things she says is that she feels terrible. She's responsible for giving it to her family. She's responsible for giving it to her daughter. She's responsible for giving it to her friend. She's responsible for giving it to her boyfriend. One of the things that she'd never considered is all this was happening during a time that syringe exchange was illegal in North Carolina. The structural factors that impact the decisions that we make had never occurred to her, that she didn't have many choices. She didn't know she had hepatitis C, but yet she carries and bears all that guilt. Next slide. When treatment providers hear these self-blaming stories coming from our own mouths, it reinforces their own stereotypes. It becomes a never-ending vicious cycle. So often we say things trying to make sense of our lives. So we say things like, thank God I went to jail. It was a good thing I went to prison. I would have never stopped using, without considering that possibly we could have gone somewhere else and it not have been so devastating to our lives. But many times we reinforce these narratives because we've never been given another way to think about the issues. Next slide. So here is our educational tools. I'm not going to go through them, but we have educational tools for the first and second year on that link. So I'm out after the webinar if anybody's interested. Next slide. there's so many justifications for why we deny drug users care. You know, you just heard one of the old pieces. We don't hear that as much anymore. We've been fighting against denial of treatment. People aren't sick enough yet. But, you know, if you heard that once 5 years ago or 10 years ago, then you're not going to know that things have changed now. So many drug users don't have accurate, up-to-date information that does not still work like that, and that they can come in and that they deserve and have a right to health care. This idea that we'll just reinfect, well, if we're not given knowledge and information and given the tools, it's a possibility. But when we have access to sterile supplies, when we have access to what we need to take care of ourselves, education. You know, one of the things we spent a lot of time doing in this group was talking about planning for unplanned behavior, planning around our substance use so that we could stay safe, so that we wouldn't put ourselves at risk. Next slide. The importance of planning for unplanned behavior. So this is what we were talking about. We need to start thinking about what are the things that are going to get in our way as drug users that we know are going to happen and we need to plan for so that we don't put ourselves at risk. So much of the group we spent with the women, we talked about, hey, when are the times you put yourself at the most risk? When does harm reduction fail you? When do things break down? When are you at risk? And some of them were being dope sick and not being able to wait for a clean syringe, sharing with a partner because you'd already shared everything else, and being stuck in some unclean or an environment that you couldn't take care of yourself. And so we talked about different ways to take care of yourself. Frustration about not being able to hit veins was one of the big ones. And so we got everybody vein finders and we taught everybody good vein care. And it really made a hell of a difference. I mean, to watch people saying that they just could not hit themselves and they were always at high risk because they were so frustrated, to go from that place to a place where people were able to calm down, take it slow. They had the skills so they could do this easier. Really made a huge difference. Next slide. So why did we get hepatitis C? You know, we have we have so many stories that we tell ourselves about why this happens to people that use drugs. And so many of the women in our group talked about, well, this is just what happens. This is what happens to drug users. This is just what we deserve. And that is not okay. Next slide. We talked a little bit about this. Can go on to the next slide. Next slide. So we know that the first syringe exchange, oh my. So we know that, well, at the beginning of the group, through the women's, many of the women spoke about themselves as drug users, but very few of them identified as sex workers. By the last few sessions, almost all of the women identified as sex workers as well. This is key because identification as sex workers is the first step to allowing marginalized sex workers into a larger community body of harm reduction knowledge. So often people are not identifying as sex workers and we're not reaching that community. So we really felt like through this story sharing group, we were able to reach women in a way we had not been able to reach women before. We had people come in and talk about many different issues. And one of the issues we had people come in and talk about was sex work and domestic violence. The women we saw in our group all identified and all were able to process trauma and really share more stories and more information with us that helped us understand the barriers to care and the traumas that prevent us from being able to access our health. Next slide. So narco-feminism is the project that we've been working on for a long time, and narco-feminism is a way we bring stories and the stories of real people to life, and we examine the structural factors and we start talking about what's really going on. This has been really important. allowing people to share their story, helping people to see that they're not to blame for everything. This is such a huge piece. As we worked with the women, it became more and more clear that they did not trust the medical community that they were in. I mean, they didn't trust the doctors that they knew, or they didn't know. They didn't have health relationships. They really just didn't have anywhere they felt safe accessing treatment. And through this story sharing and through this process, they really felt connected and more connected with our SSP. And one of the things we heard is, this is where we access health. This is where we trust folks. And so this really brings us to a point where we know that we need to be creating a health hub at our syringe service program. So this is what we are beginning to work on, is developing this health hub where we provide hepatitis C treatment, testing, treatment, and cure from the actual exchange. Because when we send people out, we lose them. Next slide. Next slide. Next slide. You can just move to the next slide. You can cut some of this out because I'm going to just tie it up at the end here. So I'll start here. So we are working to provide a health home to ensure good treatment for people that use drugs, good education and support to prevent reinfection. So right now we have written grants and we're working so that we can, through telehealth, provide hepatitis C treatment and treatment for opioid use disorder and PrEP from the exchange. This is where people feel safe. This is where people feel comfortable. And over the last 3 years that we've been doing this work, it's become very, through surveys, through focus groups, through everything that we've done, that people feel comfortable with us. People feel comfortable where they're not stigmatized. People feel comfortable where they have been treated with dignity and respect. People feel comfortable where they've been given honest information so that they can care for themselves and care for their health. And now it's our responsibility to provide them a health home so that they can be treated and cured for hepatitis C. Thanks.
Well, thank you so much, everybody who attended our session. If you have any question, there will be a Q&A at the end. Thank you.